Welcome. Before we begin, please note that this presentation is for educational purposes only and is intended for healthcare professionals. The information provided does not constitute medical advice. Always consult current clinical guidelines for patient care. The content of this presentation reflects evidence as of January 2025. In this presentation, we will explore the transformation of diabetes care, moving from a singular focus on insulin to a more holistic approach of precision medicine. We've witnessed a significant paradigm shift, moving away from a purely glucose-centric model to one that prioritizes cardiorenal protection. The primary goal now is not just to control blood sugar, but to actively prevent cardiovascular disease, protect the kidneys, and manage heart failure. Our new arsenal of medications, including GLP-1 Receptor Agonists, SGLT2 Inhibitors, and dual GLP-1/GIP agonists, are disease-modifying therapies that address these complications directly, going far beyond simple hyperglycemia management. Let's start by reviewing the traditional medications that have long been the foundation of diabetes treatment. Metformin is typically the first-line therapy, known for reducing hepatic glucose production and improving insulin sensitivity. Sulfonylureas work by stimulating insulin secretion, but they carry a risk of hypoglycemia. Thiazolidinediones, or TZDs, are PPAR gamma activators, but they can cause edema and carry a risk for heart failure. Finally, DPP-4 inhibitors offer modest efficacy and are weight neutral. While these are foundational therapies, they lack the specific cardiovascular and renal protection offered by the newer agents we will discuss. The advent of GLP-1 receptor agonists marked a revolution in diabetes care, moving beyond simple glucose control. These agents mimic the effects of the incretin hormone GLP-1, which increases insulin secretion, decreases glucagon, and slows gastric emptying. Key agents in this class include Semaglutide, Liraglutide, and Dulaglutide. They provide potent A1C reduction, typically between 1.5 to 2%, and also lead to significant weight loss. This was the first class of drugs to demonstrate a clear benefit in reducing cardiovascular mortality, as shown in the LEADER and SUSTAIN-6 trials. GLP-1 receptor agonists have also been shown to slow the progression of chronic kidney disease. They reduce the risk of kidney failure and end-stage renal disease. The LEADER trial, for example, demonstrated a 22% reduction in kidney outcomes. The mechanisms behind this protection include a reduction in glomerular hyperfiltration, lower blood pressure, and anti-inflammatory effects. These agents can slow the progression from microalbuminuria to proteinuria and have an additive benefit when combined with SGLT2 inhibitors, leading to a significant reduction in serious renal events. In patients with coronary artery disease, GLP-1 receptor agonists have been shown to reduce major adverse cardiovascular events, or MACE, which include non-fatal myocardial infarction, stroke, and cardiovascular death. The mechanisms for this benefit include the stabilization of atherosclerotic plaques, improved endothelial function, and reduced inflammation. For secondary prevention, early initiation of a GLP-1 receptor agonist is recommended for all patients with coronary artery disease. Furthermore, the combination of a GLP-1 receptor agonist with an SGLT2 inhibitor can reduce the risk of myocardial infarction even more. In patients with heart failure with reduced ejection fraction, or HFrEF, GLP-1 receptor agonists offer benefits through weight loss and improved hemodynamics. The weight loss reduces both cardiac preload and afterload, while the hemodynamic effects include lower blood pressure and improved cardiac energetics. Clinically, this translates to a reduction in heart failure hospitalizations in patients with diabetes. The synergy with SGLT2 inhibitors is also notable here, with the combination reducing heart failure hospitalizations by 16%. These agents are particularly essential for obese patients with HFrEF to reduce the workload on the myocardium. In heart failure with preserved ejection fraction, or HFpEF, the pathophysiology is often driven by obesity and inflammation. GLP-1 receptor agonists address this connection by reducing epicardial adipose tissue and myocardial stiffness. The resulting weight loss of 5 to 10% can improve exercise capacity and symptoms. Again, we see enhanced outcomes when these agents are combined with SGLT2 inhibitors. While GLP-1 receptor agonists are highly effective, They are associated with gastrointestinal side effects, most commonly nausea, which can affect 20 to 40% of patients, as well as vomiting and diarrhea. These effects are due to delayed gastric emptying and activation of CNS receptors. Fortunately, these side effects are typically transient and resolve within 2 to 4 weeks. The key management strategy is to start low and go slow with gradual dose titration. Advising patients to eat smaller, more frequent meals and to stop eating when they feel full can also help. It's also important to address the rare but serious adverse events associated with GLP-1 receptor agonists. While pancreatitis has been a concern, robust clinical trials have not shown an increased risk. In fact, the lifetime risk of pancreatitis is slightly lower in users. There is no robust human evidence for an increased risk of thyroid cancer, and these agents are only contraindicated in patients with a personal or family history of medullary thyroid carcinoma. Gallbladder issues, such as cholelithiasis and cholecystitis, are rare and are linked to rapid weight loss. Other extremely rare events include acute kidney injury from dehydration and Fournier's gangrene. From a clinical perspective, the cardiovascular and renal benefits of these agents substantially outweigh these rare risks, but it is always important to discuss both the risks and benefits with the patient. The future of diabetes care is moving towards dual and even triple agonists. Tirzepatide, brand name Mounjaro, is the first in-class dual GIP and GLP-1 receptor agonist for type 2 diabetes. It is also approved for chronic weight management under the brand name Zepbound. Emerging agents in this class include retatrutide, a triple GIP, GLP-1, and glucagon agonist, and survodutide, a dual glucagon and GLP-1 agonist, both of which are currently in trials. These dual agonists offer superior efficacy, with HbA1c reductions of 1.5 to 2.5% and weight loss of 15 to 22%. The mechanism is a synergistic activation of both GIP, which enhances insulin secretion, and GLP-1, which promotes satiety. SGLT2 inhibitors are another class of medications that offer multisystem benefits beyond just glycemic control. They work by blocking glucose reabsorption in the kidneys, leading to the excretion of about 70 grams of glucose per day, which equates to a 280-calorie deficit and subsequent weight loss. They also lower blood pressure by 4 to 6 millimeters of mercury systolic and 1 to 2 millimeters of mercury diastolic through osmotic diuresis. Additionally, they lower serum uric acid levels, which can protect against gout, and they have been shown to reduce liver fat content, which is beneficial for patients with non-alcoholic fatty liver disease. Finally, they can increase erythropoiesis, leading to a rise in hemoglobin and hematocrit. Tirzepatide has also demonstrated enhanced kidney protection in patients with chronic kidney disease. It has shown superior outcomes in reducing a composite of kidney events compared to GLP-1 receptor agonist monotherapy. The dual GLP-1 and GIP action provides additive renal protection. The significant weight loss of 15 to 22% also contributes to this benefit by reducing glomerular hyperfiltration and improving hemodynamics. This makes tirzepatide an ideal agent for CKD patients who require aggressive metabolic control. Optimal protection is achieved when it is combined with an SGLT2 inhibitor. The SURPASS-CVOT trial confirmed the cardiovascular safety and efficacy of tirzepatide in patients with type 2 diabetes and established cardiovascular disease. The results showed that tirzepatide matched the GLP-1 receptor agonist dulaglutide in reducing MACE by about 20%. However, tirzepatide demonstrated superiority in metabolic control, with better A1C and weight reduction, as well as better renal outcomes. The mechanism for these benefits is a combination of weight loss, improved lipids, and improved endothelial function. This makes tirzepatide a first-line consideration for patients with coronary artery disease and obesity. Emerging evidence also supports the use of tirzepatide in heart failure. The superior weight loss of 15 to 22%, compared to 3 to 5% with GLP-1 receptor agonists alone, leads to a substantial reduction in cardiac preload and afterload. This is particularly beneficial in HFpEF, where it more effectively addresses the obesity-driven pathophysiology. Tirzepatide is a potent adjunct to standard heart failure therapies, including SGLT2 inhibitors, The safety profile of tirzepatide is similar to that of the GLP-1 receptor agonist class. The most common side effects are gastrointestinal, including nausea, diarrhea, and vomiting. These can be managed by dose titration, starting at 2.5 milligrams and increasing monthly. Serious events are rare and similar to those seen with GLP-1 receptor agonists, including pancreatitis and cholelithiasis. There have been some emerging reports of musculoskeletal pain and palpitations, but the causality is unclear. Overall, tirzepatide has a favorable safety profile. Now let's turn our attention to SGLT2 inhibitors, which are powerful cardiorenal protectors. These agents work by blocking glucose reabsorption in the proximal convoluted tubule of the kidney. Key agents in this class include empagliflozin, dapagliflozin, and canagliflozin. A newer agent, sotagliflozin, is a dual SGLT1 and SGLT2 inhibitor approved for heart failure. The primary benefit of this class is the reduction in heart failure hospitalizations, cardiovascular death, and the progression of chronic kidney disease. In patients with chronic kidney disease, SGLT2 inhibitors have been shown to reduce the risk of kidney failure and the need for dialysis by 30 to 40%. They achieve this by restoring tubuloglomerular feedback, which reduces intraglomerular pressure. This makes them an essential therapy for patients with chronic kidney disease and proteinuria, regardless of their diabetes status. They also provide additive protection when combined with GLP-1 receptor agonists. SGLT2 inhibitors have become a cornerstone therapy for heart failure with reduced ejection fraction, or HFrEF. The DOP-HF and EMPEROR-reduced trials established them as a standard of care. Sotagliflozin, the dual SGLT1 half inhibitor, has also shown proven benefit in heart failure in the SOLOIST WHF trial. Clinically, these agents reduce heart failure hospitalizations by about 30% and improve survival. The mechanisms for this benefit include natriuresis, improved cardiac energetics, and reduced preload and afterload. The typical doses are 10 milligrams of empagliflozin or dapagliflozin, or titrated sotagliflozin. A new and exciting frontier for GLP-1 receptor agonists is the treatment of obstructive sleep apnea, or OSA. The SURMOUNT-OSA trial showed that tirzepatide significantly reduced the apnea-hypopnea index, or AHI. The mechanism is the substantial weight loss, which reduces upper airway collapse and inflammation. This leads to improved sleep quality, reduced daytime sleepiness, and a lower risk of cardiovascular events. It is now recommended to screen for OSA in obese patients with type 2 diabetes and to consider a GLP-1/GIP agonist as a primary therapy. This slide provides a unified view of the mechanisms of action of these new drug classes, targeting what has been called the ominous octet of hyperglycemia. SGLT2 inhibitors work on the kidney to increase glucose excretion. GLP-1, GIP, and DPP-4 inhibitors work on the pancreas to increase insulin and decrease glucagon. GLP-1 and GIP agonists also work on the brain to increase satiety. In the gut, GLP-1, GIP, and alpha-glucosidase inhibitors slow glucose absorption and gastric emptying. Metformin and TZDs work on the liver to decrease glucose production, and on muscle and fat to increase insulin sensitivity. SGLT2 inhibitors have redefined the treatment of heart failure with preserved ejection fraction, or HFpEF. They are the first evidence-based therapy and the only class with a Class 1 recommendation for HFpEF. The landmark DELIVER and EMPEROR-PRESERVE trials showed a 21% reduction in cardiovascular death or heart failure hospitalization. The mechanisms for this benefit include a reduction in epicardial adipose tissue, inflammation, and myocardial stiffness. This is a true breakthrough, transforming a stiff ventricle into one with increased compliance and improved relaxation, setting a new standard of treatment. In patients with coronary artery disease, SGLT2 inhibitors also reduce recurrent events. They do this by stabilizing atherosclerotic plaques, improving endothelial function, and reducing inflammation. This leads to a reduction in MACE in patients with CAD. Importantly, these cardiovascular benefits occur regardless of glucose lowering. This makes them an essential addition to statins and antiplatelets for secondary prevention. The combination with a GLP-1 receptor agonist maximizes the reduction in events. Like all medications, SGLT2 inhibitors have side effects that need to be managed. The most common are genital mycotic infections, such as Candida, which occur in 10 to 15% of patients. These can be managed with good hygiene and antifungal medications. Volume depletion can also occur, leading to orthostatic hypotension and dizziness, so it's important to ensure adequate hydration. Polyuria or increased urination is an expected side effect due to osmotic diuresis. There is also a slight increased risk of urinary tract infections, around 5 to 10%. The key management strategies are to emphasize hygiene, hydration, and monitoring to achieve optimal patient outcomes. Euglycemic diabetic ketoacidosis, or EDKA, is a rare but serious complication associated with SGLT2 inhibitors. The paradox of EDKA is that it is diabetic ketoacidosis that occurs with near-normal glucose levels, typically below 250 milligrams per deciliter. While it is rare, with an incidence of about 0.1%, it is life-threatening. Triggers include surgery, acute illness, dehydration, and a reduction in insulin. It is crucial to follow sick day rules and to hold the SGLT2 inhibitor during an illness or for 3 days before a planned surgery. The symptoms are the same as for traditional DKA: nausea, vomiting, abdominal pain, and dyspnea. The monitor on the slide highlights the key features: normal glucose, but high ketones, triggering an alert. The sick day protocol is to hold the SGLT2I, monitor ketones, hydrate, and seek medical help. In addition to EDKA, there are other rare but serious adverse events associated with SGLT2 inhibitors. Fournier's gangrene is an extremely rare but serious perineal infection that requires urgent surgery. Acute kidney injury can occur, particularly with severe volume depletion, so it's important to monitor renal function. An increased risk of bone fractures has been observed in some trials, although the mechanism is unclear. Amputation risk has been noted with canagliflozin, so it should be avoided in patients with high-risk peripheral vascular disease. From a clinical perspective, it's important to weigh these rare risks against the substantial cardiorenal benefits and to have a thorough discussion with the patient about the risks and benefits. The combination of a GLP-1 receptor agonist and an SGLT2 inhibitor offers synergistic benefits. These two classes have complementary mechanisms, both metabolic and hemodynamic. The outcomes are impressive: a 41% reduction in MACE, a 43% reduction in cardiovascular death, a 29% reduction in heart failure hospitalization, and a 57% reduction in serious renal events. This makes the combination a strong consideration for high-risk patients with type 2 diabetes and established cardiovascular disease, chronic kidney disease, or heart failure. The strategy is to provide comprehensive cardiorenal protection. This slide presents a practical treatment algorithm for selecting the right agent for the right patient. The first step is to assess for comorbidities, including atherosclerotic cardiovascular disease, heart failure, and chronic kidney disease. For patients with ASCVD, either a GLP-1 receptor agonist or an SGLT2 inhibitor is recommended. For patients with heart failure, both HFrEF and HFpEF, an SGLT2 inhibitor is first line. For patients with chronic kidney disease and albuminuria, an SGLT2 inhibitor is also first line. If the HbA1c remains above target, a complementary agent should be added. For patients who need additional support with obesity or weight management, Tirzepatide should be considered. This slide focuses on diabetes management in chronic kidney disease, with the goal of protecting the failing kidney. The clinical guidelines are clear. SGLT2 inhibitors are essential for patients with CKD and proteinuria, as they reduce the risk of kidney failure by 30 to 40%. GLP-1 receptor agonists can be added for patients with coexisting cardiovascular disease or for additional renal protection. Metformin should be dose-adjusted for eGFR and avoided if the eGFR is less than 30 milliliters per minute. Sulfonylureas should be avoided due to the high risk of hypoglycemia. The overall goal is to slow the progression to end-stage renal disease and to reduce cardiovascular events. In heart failure, the management of diabetes requires a balance between glycemic and hemodynamic goals. For HFrEF, SGLT2 inhibitors are the cornerstone of therapy, reducing hospitalizations by 25 to 30%. A GLP-1 receptor agonist can be added for weight loss. For HFpEF, SGLT2 inhibitors are first line, and a GLP-1 receptor agonist or tirzepatide is crucial for patients with an obesity phenotype. It is important to avoid thiazolidinediones due to the risk of fluid retention and saxagliptin due to the risk of heart failure. The goal is to prioritize hemodynamic improvement over intensive glucose lowering. For patients with established coronary artery disease, the focus is on a secondary prevention strategy. This requires aggressive management. The preferred agents are GLP-1 receptor agonists and SGLT2 inhibitors, as both have been shown to reduce MACE. The combination of a GLP-1 receptor agonist and an SGLT2 inhibitor provides comprehensive protection. Standard care, including statins, antiplatelets, and ACE inhibitors or ARBs, should be continued. Sulfonylureas should be avoided due to the risk of hypoglycemia. The protective action is comprehensive cardiovascular risk reduction. Let's summarize the key takeaways from this presentation on transforming diabetes care. The first is the paradigm shift from a glucose-centric approach to one that prioritizes cardiorenal protection. The selection strategy is to treat based on comorbidities such as heart failure, chronic kidney disease, and atherosclerotic cardiovascular disease, not just on HbA1c. The combination of a GLP-1 receptor agonist and an SGLT2 inhibitor provides synergistic organ protection. Tirzepatide is a new standard for superior metabolic control. And finally, the risk-benefit analysis clearly shows that the manageable side effects of these new agents are far outweighed by their life-saving outcomes. The checklist for modern diabetes management includes cardiorenal protection, comorbidity-based treatment, synergistic combination, superior metabolic control, and life-saving outcomes. This slide provides a practical 5-step framework for individualizing diabetes therapy to achieve maximum benefit. The first step is to assess the patient's characteristics, including age, comorbidities, and obesity. The second step is to identify their risk factors, such as ASCVD, heart failure, CKD, and proteinuria. The third step is to select the appropriate agent, a GLP-1 receptor agonist for cardiovascular disease and weight management, an SGLT2 inhibitor for heart failure and chronic kidney disease, or tirzepatide for metabolic control. The fourth step is to combine therapies, initiating combination therapy for high-risk patients. The final step is to titrate and monitor, optimizing the dose and watching for side effects. The future of diabetes care holds even more promise, with emerging therapies and a move towards precision medicine. Key points to watch for include triple therapy, combining a GLP-1 receptor agonist, an SGLT2 inhibitor, and a mineralocorticoid receptor antagonist like finerenone for comprehensive protection. New formulations are also on the horizon, including oral GLP-1s and combination pills. Precision medicine will involve genetic profiling for personalized drug selection. And technology will play an increasingly important role, with AI-driven insulin dosing and integration of continuous monitoring. The ultimate goal is the prevention of complications as the primary objective. In summary, this presentation has outlined an evidence-based approach to modern diabetes management. The new paradigm is cardiorenal protection. Metformin remains the foundation of first-line therapy, except in patients with a low creatinine clearance. GLP-1 receptor agonists are indicated for patients with cardiovascular disease, heart failure, chronic kidney disease, and obesity. SGLT2 inhibitors are for patients with HFrEF, and for those with CKD and proteinuria, they can reduce the risk of kidney failure by 30 to 40%. Tirzepatide offers superior metabolic control and weight loss, and the combination of these agents provides synergistic benefits for high-risk patients. The final summary diagram shows how an evidence-based approach, targeting the heart, kidneys, and metabolic and weight parameters, leads to synergistic benefits, improved patient outcomes, and comprehensive care.